Alrighty, I think everyone in the waiting room has joined. So welcome everyone to our fifth meeting of the Emerging Technology Committee. My name is Shelby Rowell. I am a senior analyst at the Kansas Health Institute, and we are so glad to have you with us today. So before we get started, we would like to go through just a few quick features. Wyatt, if you could advance the slides, please. Before we get started. Perfect. Alrighty. So as you all are aware, if you have any questions during today's chat, feel free to add those within the chat section or just come off mute and ask your question. This session is being recorded and live streamed so that others across the state can see what the committee is working on. And then also, if you have any technical questions or difficulties today, please find Carson DeWeese within the participants list, and you can chat her with any questions you may have. So moving on to our agenda, I think Wyatt is resharing his screen. So moving on to our agenda, we'll first again be starting with this welcome and overview. We'll then move into a short meeting recap, just going over the work that we did in our last session, which was in person and hybrid for those of us who joined online. Then we'll turn it over to Marty to provide some ETC updates. Go into our Technology Committee work plan and key activities, providing a little bit of an update on the work that we did in the past month, pulling all of that information together that you all told us in that last meeting to put that into our work plan. And then we'll spend the majority of our time in today's meeting talking about eligibility and prioritization criteria for the ET grants moving forward. So thinking about ambient AI as well as revenue cycle management. And then finally, we'll end with next steps and a few updates for the committee. Next slide, please. So looking at our meeting schedule, this is our fifth meeting within this first year. As a reminder, our next meeting will be on September 24th, and it again will be virtual. So now we'll go into our kind of committee recap, looking at what you all worked on in our last session, and we covered a lot of ground. So first, we looked at creating a shared vision for the work. I think in the past few months, we've seen there's been a lot of kind of transformation on what we've been focusing on. So we had you all do a ride around exercise, imagining it's 2020 or 2030, and then thinking about because the ETC exists, what do we want that future Kansas to look like? So Wyatt will be going over that information in his section, again, looking at that work plan vision. Next, we talked a little bit about the ETC use case model. So throughout this conversation, we asked you all, would you like to have the funding move from the current ET grants model and then move that into something that more closely aligns with what we're doing within the ambient AI RFP and RFA. So that was a decision that you all made, and from that, 2 priority use cases were selected. So again, you all had the option to select, I think, across 8 different use cases within the revenue cycle management category, as well as workforce optimization. And those 2 priority use cases that you selected were within that RCM space. Then going into the work plan focus discussion, you all identified 4 different work plan focus areas that, again, Wyatt will be covering, so we won't spend too much time here, but really looking at what you want to focus on, and then also thinking about what does the requirements look like for those different areas, what types of activities you want to do within those areas. And then finally, looking at the needs assessment requirement. So we talked a lot about if we needed to do a statewide needs assessment. I believe Kristen will be providing a little bit more context around what this is going to look like within the RFA process this year. But you all decided that it was necessary to have that needs assessment as part of eligibility for the upcoming Ambient AI grant. And then finally, again, that year 2 grant pool, this is tied to the use case model confirmation, but this is essentially the decision that you all made about taking that roughly $10 million worth of funding and then putting that into that use case model. So this is, again, a quick recap of what we discussed in our last meeting. As a reminder, you do have the meeting summary that goes into quite a bit more detail in your inboxes. So that will have come from Sheena Schmidt. With that, I think we can go ahead and transition into our next section, and I will hand it over to Marty Ross to provide an update on the ET grants.
Thank you, Shelby, and good afternoon, everyone. And thank you so much for everyone being part of this call. I was so energized after our in-person meeting at the end of July, and I'm very excited that you're keeping this momentum going forward with this excellent participation in this virtual meeting. So what's happened since we met at the end of July? KDHE has prepared its year 1 progress report as well as its year 2 budget request. Those have been approved now by the governor and will be submitted to CMS, if not today, tomorrow, which is ahead of the August 31st deadline. As you'll recall, the budget was built based on the award that Kansas received in year 1, which is the $221.89 million. There is still the potential of Kansas receiving additional dollars. KDHE is in the process of evaluating where those dollars potentially would go, but let's not worry about that issue now. Be aware that part of the state's plan for year 2 is an acceleration of the grant programs. The state's RHTP plan includes multiple grant programs, starting with the Regional Partnership Grant Program. That's roughly, I believe, don't quote me on these numbers, about $40 million. The REH Conversion and Transformative Capital Grant Program, slightly less money in that program. New this year will be the Non-Emergency Transportation Grant Program. It's small, about $3 million, but help communities identify ways to enhance transportation for patients requiring care. The Accountable Food is Medicine Community Health Worker Program. It will place its RFP out as well for opportunities for hospitals and clinics to secure the services of community health workers as part of the Accountable Food is Medicine program. The RFPs for these programs are scheduled to be released on September 18. KDHE is, and that was announced today publicly to the members of the Kansas Rural Health Innovation Alliance, which is the advisory board of stakeholders to KDHE and the governor. That September 18 deadline is basically 20 minutes away in our HPT time. So it's something folks are we want folks to be paying attention to very soon. KDHE intends to look at the application process to simplify the information that needs to be submitted with those applications. It also, through KHI, is intending to provide technical support and assistance for applicants as well. It's a quick turnaround. The application dates, Kristen, you sent me these dates and I didn't pull them up quickly enough. There'll be a webinar planned for September 25 to review those RFPs, and applications will be due on November 6 with the anticipation of making award announcements December 18. You notice I did not mention the Emerging Technology Program in that list. And in fact, in the KDHE's communication to Korea, they noted that it is a grant program with $10 million that is being restructured for year 2. And so this is the point where I get to tell you that we caught the bus. And now what do? KDHE accepted your recommendation to move that $10 million to ETC for purposes of identifying and then launching AI and other technology programs to support a broad swath of the rural provider community. But part of the reason this bus is moving really, really fast, that we are bound to the same timeline that the governor and KDHE have outlined for the other grant programs. So work we had anticipated having 10 months to complete, we will now effectively complete in, 2.5. And it's going to take an incredible input from this team to accomplish that. Kristen and the KHI team and I have been kind of preliminarily trying to make a calendar work, and appreciating the effort that's going to be required as part of that. And that's what we're going to discuss today. So let me back up and sort of give you a rough vision. And this is really taking what we discussed at the end of July and pulling together how we progressed those thoughts since then. There is carried over from year one, this work on ambient listening AI. As you'll recall, there are dollars in year one to provide those facilities that operate on Oracle, the funds to purchase the Oracle Ambient AI product. And in fact, we have executed the agreement with Great Plains Health Alliance for its 28 hospitals. Scott, that's where you send the little clappy sign up, okay? And we are in the process of executing those agreements with the other 9 facilities that operate Oracle. That's good. Thank you, Scott. That means in year 2, and as we've been discussing, year 2 is when we focus in then on the non-Oracle solutions. So rather than, we've been developing the RFP for that, and we've known that that would be an RFP to be funded with year 2 dollars. And in fact, those dollars are in the year 2 budget to accomplish that. But again, to be accomplished in very short order. Identifying products and then identifying a process by which we make those funds available to providers, and then actually go through the contracting process to make that happen. The $10 million I referenced to is for that use case that we discussed back in July, which is providing to rural providers a revenue cycle solution, and identifying a product that meets very specific, it's not specific specifications. I'm getting tripped up there, sorry, but there are very defined specifications that those products meet, and that then as that product is identified, making it available to providers. That all requires creation of criteria, creation of a rollout campaign, a media blitz, shall we say, to make sure that providers are aware of the opportunity. It requires an application process as simple as possible. We referred to that as having very objective criteria that you could literally score applications and put them in priority order for funding. And then it requires that criteria, that prioritization criteria, to identify how they will be funded. So that's our challenge for today, is for us to be able to go back to KDHE saying, here's the plan we have to make this happen. Here are the deadlines we need to follow. At this point, not exactly mirroring the deadlines that they're creating for the other programs, but of course, staying very closely aligned with those deadlines. And there's some degree of confusion here. I'm the first to admit it, because we're going to be running the ambient AI opportunity in conjunction with the RCM solution opportunity. And not all hospitals or all clinics or all providers will be applying for both. For example, our Anchor Hospital Advancement Program hospitals, those 10, have pursued their own RFP for RCM, as Kristen can tell you in nauseating details, and she's been in the middle of all of that. But they are running on their funding under that initiative. So those 10 hospitals are not part, and their clinics are not part of what we're doing on RCM here. For ambient AI, we won't have the Oracle hospitals and their clinics involved because they will have already received that funding. But it is certainly going to be a broad invitation to participate. So what we have here today is focusing first on eligibility. who will these funds be made available to? So who gets an application and can complete it and then be scored on the prioritization criteria? We started this conversation in July, but we need to really bring it to a full decision. And part of that is driven by the fact that we have limited funds. We don't have an unending resource, at least at this point. We don't have a resource that can guarantee the best solution for every single rural provider. So it is up to this committee to make recommendations on how those funds can be applied most effectively. Appreciate that we are not simply writing checks. We're not saying, okay, here's a check for $1 million for you to go find the solution that you want. Because again, the lesson of the Emerging Technology Grant Program was that that approach is really a drop in the ocean and is not truly transformative to the healthcare system. This approach, where we identify solutions that match specifications and are able to negotiate favorable pricing and favorable implementation support for our hospitals, and then offering that solution to a wide range of providers who will then have their costs reimbursed, we believe has the greater impact on the system overall. That we're going to get these tools in the greatest number of hands who need the technology the most. So our prioritization, the eligibility criteria, are really saying in year 2, for the funds we have available, here's who should be eligible. Appreciating that year 3, there could be additional funds to expand to different provider types. So that's conversation 1, eligibility. I think as we've discussed it internally, and certainly want your feedback on this, it probably makes sense to have the criteria the same for both ambient AI and our CM solution. But again, you are in the trenches and can help us really discern if that makes sense. The second part of this conversation, the hard part of this conversation, is the prioritization criteria. I mean, that's what we sold KDHE on, is that we could create objective criteria that you could assign a score to an application and then place them in order. And you start with number 1 and you fund number 1, you fund number 2 until you hit that $10 million cap. And you make awards, again, maximum impact, but making sure that we are meeting what we believe are the most significant needs in the rural communities at this point in time. Sheena, Shelby, Kristen, Wyatt, anything to add to that sort of broad overview?
I think you got it covered.
Okay. Any
Beautiful.
questions? Any questions here from the team, except for all the words I got wrong, but any questions from our larger team here on the ETC about this approach? Okay, so this is the part where I scare you. To make this work, to hit that end of the year expectation from KDHE and the governor's office, we literally have to start putting things in KDHE's hands next week. That means we have to have ironed out eligibility and prioritization criteria and an application form to KDHE shortly after the Labor Day holiday. Get their approval on that. We're thinking on a September 15 webinar to roll this out broadly. It's also going to be a full court press engaging many of you as well as members of Korea to communicate this information to their members so they have the opportunity to complete the application. Again, keep that application as simple as possible, but it will include in it an assessment. Those assessment questions that Kristen has discussed with us, we are going to bake that into the application so that information is then available to inform the RFP. That may sound a little cart before the horse, but that's how you make this process work. Or at least Kristen assures me that's how we make this process work, is that we are gathering the applications, gathering the intelligence about our applicants, that informs the RFPs that we put in the field. So we send those RFPs out. We then take the applications that we've received, we prioritize them and make recommendations to KDHE on who should be awarded. At the same time, we're evaluating the responses to the RFPs and making recommendations to KDHE on which vendors to approve. And then as those vendors are approved, that coming back to complete the contract negotiations, and then marrying those up with the applicants. There's a process in here. So if you figured it out, we're selecting the applicants, identifying the applicants before we actually have the product that we're going to give them. And so we're going to advertise it as such, that you are saving your space in line to secure funding to purchase and implement a product that meets specifications in the RFP. The RFP process is ongoing, and as those vendors are identified, there'll be a contract that they hold with CCA, which basically defines the requirements for receiving reimbursement. But in addition, the providers themselves will hold a contract with CCA that is the vehicle by which we make payments on invoices. And that's exactly how it's working under the Oracle product. Seems to be working right now. I appreciate wheels can come off at any point in time. But we believe by running these next to each other, we certainly can focus people's attention on the opportunity and again, achieve by the end of the year, the identification both of the vendor as well as those applicants that are going to have the opportunity to implement that product. Again, back to you all for any comments that I'm missing, and then to our larger committee, any questions that you have.
Marty, do you think we break up the work effort on the two-sided marketplace here? Some folks work on the needs of the providers and some work on how to evaluate suppliers and how to, those things.
We have a plan, just stay tuned.
Oh, okay. I figured, well, I didn't know if you did.
No, that's great.
No,
No
that's
one will be
good.
left behind. Don't worry,
Stay
Dick. You will
tuned.
not have a boring fall.
We got this. And we're going to go over this in a lot more detail too, as well. And so we can continue this discussion, definitely. And thank you so much to Marty for that great explanation. We know it's a lot of information to convey. If you have any additional questions, as you process and as we're continuing to talk about the timeline and the work plan and how it will all flow, please come off mute, share. We're not doing any fancy things today. It's really to focus on discussion and getting that meaningful feedback, and put them in the chat as well. Thank you so much. Anything else you wanted to share, Marty? Good.
No, just to say, I mean, if this works, this is an amazing opportunity for this group to really influence transformation in the state of Kansas, because yes, we're going to do if RCM is the first use case, then what's the next use case and the next use case, to really be providing these solutions so broadly available throughout the state. I think it has its down. I'm the first to say it will have its detractors. It will have problems, but I think on balance, this is how we use these dollars as effectively as possible.
Yep. Awesome. Okay, we're going to switch. We'll continue the discussion. I'm going to turn it over to Wyatt to walk us through, reiterating some things, knowing that it can shift a little, but what the plan is for now, how the work plan has the bones. I want to assure you the bones of the work plan and everything that we said we wanted to do are still in the work plan. We just had to shift based on the accelerated timeline. So I'll turn it over to Wyatt, and we'll get things moving so we can get to the feedback section.
Yeah, thanks, Sheena, and thanks, Marty. So we zoomed in to give you where we're at now and some of the work that really needs to happen quickly, and that's where we're going today. I'm going to zoom us back just a little bit to sort of say, where does this all fit in this broader work plan for year 2, and show you how some of the things we discussed at our last meeting came together. So one of the things we did was work on a vision, and we have a draft vision for you, and I won't read it. You can read it, but a couple of things. The first sentence is really that aspirational piece. What do you want for Kansas? The second sentence is really, how does ETC fit in to creating that vision? And if folks have feedback or comments on this, feel free to drop them in chat. But hopefully this feels like it captured a lot of the discussion we had in person. The idea that Kansas rural health providers will have access to solutions that measurably improve outcomes, and that you all will support in identifying and implementing those solutions and balancing the proven technologies with the innovation and unique needs. So that's what we're working towards. And all of this work, hopefully you see how it feeds into that vision. And Doug, thanks for the thumbs up. I'm going to take that as my thumbs up to move to the next slide. So you got a preview of those focus areas. So thinking about year 2 work plan, we're going to spend a lot of time on those first 2 bubbles today. And that's where a lot of the work, but those other 2 areas that were identified, we thought about those, or what are some additional areas that you all want to wrestle with that you see as potential areas to support and add value to rural health providers in the state. So what that looks like in a very simplified sort of overall timeline is this. So the first column is September through November of this year. So it's these next few months. We've got a lot of work on those top 2 pieces, the ambient listening, AI, the revenue cycle management. That's what we're going to spend the rest of the time today talking about. By December, we get those selections made and we go into implementation the rest of year 2. As that shift happens, then we can think about what do we want to work on as a group? What do you all want to do as a committee for those guidance and standards and the centralized IT and shared services? Based on the discussion we had in person, there was more clarity on what the guidance and standards could be, and that it would be some sort of shared resource that could be provided. So that one will be the one that progress happens first on, but then there will be a shift to doing some scanning to see what information is out there and what do you all want to focus on for centralized IT and shared services, and that will continue into the second half of year 2. So that's the overall work plan. A lot of work is going to happen really quickly in the next few months on the top 2, and then we will shift as those selections are made and go into implementation. We can shift to those other areas.
Wyatt, and I may interject here just a little. So when we say environmental scan, this is something that typically, and what will happen now is that we have proposed that KHI will support conducting the environmental scan with the help of subject matter expertise on the committee. And so what that involves is kind of a broad look at other examples, other resources, from reputable sources, bringing that evidence-based information in to inform the committee so that you all can make decisions on the direction that you move forward. So KHI will be supporting that activity in addition to the facilitation activities, which is a little newer in year 2, but definitely needed and was identified in our discussions at our last meeting.
Yeah, thanks, Sheena. So we want to bring that information to you, so you can use it to inform the work. So that's what we're working on. So I hope everyone, as Marty said, feels that momentum coming out of our in-person meeting. Now we're gonna shift into the meat of today's work and today's discussion, and that is the grant eligibility and prioritization criteria. And Sheena, I will turn it back to you.
Thank you. So as Marty mentioned, the committee has both a great opportunity and responsibility now for not only the ambient AI solution, but also the revenue cycle management solution, and on an extremely accelerated timeline. So we wanted to talk through how that's going to work with you before we dive in today. So go ahead and transition. Okay, so what does that look like? Marty alluded to some of the timing of this, and I just wanted to let you know that some of these dates may shift as we're finalizing based on availability and how things are coming together. But we do know that for now, we can plan on having this timeline for both of those workflows. So eligibility and scoring criteria is set to be set by September 1st. So that's what we're going to do today. That's what we're going to spend the rest of the meeting doing today. And just to be aware, as you know, Dick, you ask a question, we are going to be asking for volunteers to do some more, with technical expertise or expertise on certain areas to weigh in once those drafts are completed after today. So stay tuned for that opportunity. Then we will have the RFA development and publication. So this RFA is focused on clinics and those that are eligible for getting the solution to apply and complete the needs assessment. There will be a webinar held so that interested applicants can learn about these two opportunities, have an opportunity to ask questions within federal and state guidance on procurement regulations, and to also, have questions if they are having to get assistance in completing the needs assessment as well. So we would just ask that you all also be willing to share once those details become available, share far and wide with your networks, and so that we can get broad participation in that webinar. Then also we'll have that will happen. Okay. So then the second piece of this is an RFP needs to go out for the vendor selection piece. While all of that is happening, we'll be reaching out through those volunteers, those groups with technical expertise, and we may be asking members of the committee also for individuals if you feel like someone else in your organization has that technical expertise that they could help assist in reviewing or providing feedback on a draft RFP for vendor selection. We'd be willing to accept, nominations and contact information that you could share with us for individuals that we might reach out to. Uh, Going back to the RFA, those responses for the potential applicants for the solution will be due in October, early October, with those determined in October 9th. And as Marty has said so eloquently, it's basically like, this is your place in line, get it. But you have a place in line once we have the RFP developed for vendor selection. Then we will reach out to you to execute those agreements to get you your solution. So any questions about the draft timeline, knowing that some may shift, the actual dates may shift.
If any of you are like me and get confused sometimes by acronyms, just remember that A means provider and P means vendor.
Vendor, yeah. Good note. Okay. All right. I think we can move along. So, as we just stated, we're moving in from use cases to RFA and RFP requirements. So we're moving through this process together, and we're doing it for two things now at the same time instead of just one. What are we going to be doing today? So we have collected a lot of general great feedback on the ambient listening AI solution. But today is when we're really getting down into the details of what will show up on the application and how it will be scored. So the who and the what. And the who and the how kind of is how we're thinking about it. So we're going to be going through for both ambient AI listening solution and the revenue cycle management, talking about who will be eligible and also how they will be scored. All right, and this is just kind of a mapping of where we are in the process for the RFA as well. Okay, so these are the buckets that we're going to be talking about today. So when we're thinking about who can apply for both of these solutions, We're going to be talking about rurality, the type of facility, and how a multi-site grantee will functionally complete the application and be treated in this process. How they are scored, we're going to be thinking about geographic distribution, technical readiness, and financial need. And we've already talked about some of these things, and so I wanted to give us a little bit of an overview on how we have thought about that. So from the themes that we've talked about so far, in terms of rurality, we've had a strong support for a tiered approach favoring frontier and rural designated sites. Making whether or not a provider is a rural, an eligibility test, or how rural they are in terms of scoring. In terms of the type of facility, there's been consensus on hospitals, primary care clinics, community mental health centers. Behavioral health has also been flagged as a high priority for the types of facilities that could apply. We're going to talk a little bit more about additional facilities for your consideration today as well. And on multi-site grantees, that question, it's kind of been an open question and kind of how to treat that. So we're going to dig into that a little bit more. How they are scored. We've talked about having kind of a statewide distribution raised as a funding priority, about how that functionally will work. We're going to talk about that. Readiness. We were talking about no site will kind of report that it's not ready. So there should be a pledge for a pledge and information from the needs assessment can kind of get us more closer to how that looks. And then financial need. We've raised it along patient volume and population served as a funding priority. But others were kind of mixed on whether financial strength should play a role in the in how applications are scored. So we'll talk through that a little bit more too. So some open questions we'll continue to sort through. And just a note, we are going, when we think about eligibility and how they're scored, eligibility for all intents and purposes, it makes sense to treat both solutions the same way. And then we've identified a few buckets for scoring, but there's only one different bucket for revenue cycle management. So as you're thinking about providing feedback, we would like to think about it like going back to the vision, thinking about functionally speaking, who should be getting this funding and how should we be treating it, kind of regardless of the topic area. But when we do have specific questions on the topic area that makes a difference, we've built that into today's discussion. Any questions? Anything I missed, team?
Only to highlight, this is forcing us to make choices.
Yeah.
And it's like you want to treat everyone fairly, but at some point we're going to have to make choices.
I might also add, as we make choices, it's not in the scheme of it, it's who do we prioritize? And that those that are not prioritized in the first year, ideally will still get the funding in a future year. But how do we serve those most in need first?
Yep.
And the potential that some types of providers may require a different solution. And so if the goal in year one is to if you can keep one number of vendors that applies to a broader types of providers, but if we know that to serve the needs of this type of provider, it would require yet a different vendor type, that would also be one of the considerations.
All right, next slide. All right, so some of the conversations we wanted to talk through with you is that what carries into what are the considerations that carries into eligibility and prioritization, because we have been more high level. So eligibility involves location, provider type, site status, interoperability commitment, and completion of a needs assessment. It's kind of like the guardrails for who's going to be able to even attempt to apply for the opportunity. And then prioritization is really we get into, okay, when we talk about rural, you're rural using the FORP definition, but the categories of rural, who should be given priority. So we'll talk through that today. Into vendor requirements, thinking about what should be in place at the vendor level to support the people that they're going to be serving or that are going to be receiving the solution. And then still open for discussion, as I mentioned, that financial need, how a multi-site will functionally apply and how they will be treated, and nailing down those provider and facility types. So, what are we going to do together today? We have prepared some questions and some things for you to reflect on given the accelerated timeline. So we've pulled together our previous discussions. We've also pulled an example from a previous RFA, which is the evidence-based practice grant eligibility. So we have something to work from. So what you see on your screen is those 3 areas that will determine eligibility. I will go over them and then we can kind of just open it up for discussion. Does that sound good? All right.
You know, just because I'm sure a lot of folks on this call are not going to be familiar with the EBP program, Evidence-Based Practice Program. This is probably the single largest statewide program in the RHTP. It is infrastructure and incentive payments to rural hospitals and rural clinics to engage in the development and implementation of evidence-based practices across multiple use cases. The payment to hospitals for infrastructure payments is $100,000. For clinics, it's $50,000. And then there is, in addition to the infrastructure payments, incentive payments that they receive for reporting on specified measures. And those are for year 1, $50,000 and $25,000. And because of the nature of the program, we had to fine tune the definition of eligibility. And over the last 6 months, we have had many opportunities to grapple with some challenges in trying to apply this. This is not to say that the EBP criteria should be the same we use for these programs, but it at least provides an example of how we've applied it.
Thank you, Marty. So first, that program to be eligible for funding included hospitals, rural health clinics, FQHCs, CCBHCs, and independent full-time physician practices. They specifically excluded long-term care facilities, dentists, chiropractors, PT, OT, SLP, speech language pathology practices, imaging centers, pharmacies, ambulatory surgery centers. So the first question, would the committee like to align with eligibility for facilities that the evidence-based practice followed, or would it like to add any other facilities that are either listed here or otherwise want to be suggested, or otherwise the committee would want to suggest other kinds of practices? So we'll open it up for discussion.
Sheena, for clarification, we are saying for both ambient
Yes.
and for RevCycle.
Yes.
So I would ask slightly differently. Is there a reason from a revenue cycle specifically that we would not want long-term care facilities or imaging centers and ambulatory surgery centers to be part of this? And I'm not asking Sheena, but for the broader group.
Well, I think long-term care facilities have a really big impact on hospitals and independent full-time practices, because I think the way things are working is it's this virtuous, non-virtuous cycle that happens. And and I don't have data on this, but there are long-term care facilities in most of these communities, I hope, or I would expect. And they usually have a pretty tight relationship with a local physician, and they usually have a tight relationship with a hospital because patients coming and going. And seems to me in terms of revenue cycle and or even ambient, I think there's just a lot of natural connections among those three players. And so that's the only thing I would say in terms of long-term care. I think they're really a pretty well integrated part of the ecosystem.
Including it, right?
Yeah, which would speak to including them. Thank you, Liz. Sorry, I didn't make that clear on the front end.
Any
I agree with
other?
that, although the revenue cycle solutions and operations of long-term care is quite different. So that would lead to some challenges in regards to identifying a vendor that would cover that in line with the other facilities.
Yeah, that was going to be my only point is I'm not sure what the technologies would be that would be efficient. And many of them that would be interested in this probably are owned or operated by a hospital and might be able to receive some benefit from the hospital being eligible.
Yeah, I think that's really good. I was thinking, for pure rev cycle, I think that's I would totally agree with what you just said. The only thing I would ask us to think through is some of the new programs, CMS, and I know there are different payment models here. And I'd have to go check to see if under the unique payment models that Critical Access has, do you guys know, are they participating in all the bundles and all the new stuff that's come out? Are they in that mix?
Some skilled nursing facilities would if they provide skilled services, which is a different level of care reimbursement model. True residential facilities probably are not, but maybe that's the distinction, is that I've never really looked at revenue cycle optimization or any of those things for skilled care. But maybe skilled care is what gets left in and not necessarily long-term care.
Yeah, that's a great observation.
Yeah, and in rural, most skilled is in swing bed.
Is in your
Yeah.
hospital, correct? Yep.
Yeah.
Well, if that's the case, I'd say looks good as it is.
Yeah.
So do we also think, as we look at ambulatory surgery centers, and where I'm coming from with these questions, as we think about rev cycle management, what we're really trying to solve for is that faster access to care, right? And removing a lot of that administrative burden and ultimately those denials. So not to say how we will end up prioritizing them, but should there be eligibility for the ambulatory surgery centers as well, knowing that's a faster path to care in our communities? They'd still have to meet the reality as well.
And I have to admit, I was the one responsible for generating the not list, and I forgot EMS. So that's another we need to consider if they should be part of it. Yeah, right. But I was the ones that were on who we didn't include in eligibility for EBP. The other was EMS.
Okay. I'll
Yes,
add
I
it.
agree, Terry.
Yeah.
Not eligible in year one.
Yeah.
Keep put myself on mute.
Okay.
I think I would put ASCs in the not eligible in year one, and only from the perspective, and this is my rural lens when I was in Western Kansas, is the intent to kind of help preserve critical services in a rural healthcare environment would be the only reason I would prioritize other facilities above ambulatory care or ambulatory surgery, not ambulatory care, ambulatory surgery.
Okay.
That's just my opinion.
I mean, the exception would be just Sarah, is if someone, just like swing beds, that they own their own ambulatory surgery centers. So anything that's under the enterprise of the health system would be eligible. Is that what we're thinking? Okay, or anybody can chime in here.
So, and I think that's one of the questions is how do we want that application to be set as well? Because, and I know Marty had come up with a definition if they're sitting on the same systems versus if they're on different EMRs or different systems. If they're on different systems, we'll want them to highlight those and apply. That may be the same application, but they need to identify each of those independent facilities. So again, part of the conversation, we want you all to really inform what that looks like. And if we could think through, not eligible year one means that we're suggesting that they cannot apply for the dollars. Do we not want them to apply? Or do we want them to apply, but say that we will have ranked criteria for facility type that once we look at the funding, if we're able to do more, we may be able to expand faster? Or do we want to say not eligible? And I think as we struggle through eligibility versus prioritization, they're two different things. And so on that eligible, we just went to not eligible year one. Do we want to say eligible for application, but maybe prioritize lower?
Although I don't want to give
Go ahead.
books.
Yeah, we don't want to give, yeah, that makes sense.
On ambulatory surgery centers, it's probably not going to matter. There's such a low percentage of those that actually exist as a standalone facility in a rural community.
There are very few independent. Yeah.
Yeah, most of them are going to be outpatient surgery departments tied to the hospital, which would be independently eligible. So it probably doesn't matter where we put it. If they meet the rurality requirement and they are a standalone ambulatory surgery center and meet the other expectations, maybe it's okay if they're in the eligible.
I really, whoever's idea it was, Marty or Kristen, you do want to know if they're running on a separate infrastructure, because I think that's two implementations.
And it's, Dick, that's probably the multi-facility question that's really hard to get your head around. And with EBP, we just finally said everyone submits a separate application. But for this, I think the answer is and I'm just choosing them because they come to mind, Salina Regional applies, then it's going to be everyone that's on their instance of, or they're on Meditech, right? So it'd be, but if they had, I think that's right. But if they had someone on a different, if some of the clinics were on Athena, then those clinics would be applying separately. Does that make sense?
I think that would be a good thing to put in the FAQs. That's a really good example there.
Okay.
Can I go back to what Kristen said? It really puts a big swing on how people can apply, and I prefer that we do prioritization approach as opposed to eligibility approach, because we may be able to then not have to do an RFP or RFA in the second year, because we've got enough applications that we can swing over to the second year if we do it by prioritization as opposed to eligibility. Like we can only take care of these first year, but we've already got enough to take care of the second year.
I will say though, that is one, but so then it would be two questions. Like, are there still some on the list that you see here or an addition that you just don't think it makes sense for? Or we just want to keep it as broad as possible, knowing that the prioritization will happen, and how to communicate that to folks.
So Sheena, is that really, as we look at dentists, chiropractors, PT, do we believe that those should be eligible or not? And if eligible, then we can then go through the exercise of where do they get prioritized?
Yeah.
And to tag on to Terry's, thank you. To tag on to Terry's question, if we do go with the prioritization versus the eligibility, then do you let it remain, or do you reopen in the year two or at a later phase to get people that potentially could have applied but didn't because of whatever reason, resourcing, lack of knowledge, etc., but they might fall lower on that prioritization list? They could then apply at a later time. I think that's just maybe a sub Part B to Terry?
So I think that's a great question, Liz, and I will defer to Marty on that, but I want to be specific, and we wouldn't walk away from eligibility. We would just broaden who is eligible, and then we would narrow that eligibility based on the prioritization. So the open that front gate broader, and then we would be able to prioritize within that to determine when they would receive the funding, if that makes sense.
So here's a question I'd love people's feedback on. Is it worse to exclude someone from participation? Or to include them, but then show them a list of prioritization where they're number 9? Like, who are we going to rank first? And who are we going to rank second? Are there some of these that we don't believe we'd ever get that far down the list? And is it more challenging to say, yeah, we included pharmacies, but they were ranked number 10, and so we knew they were never going to get funded?
And way to make some people frustrated and angry is to make them spend time on something if we ultimately know the chances of being selected are very, very slim.
That's exactly what I was just getting ready to say. Waste people's time and thinking,
Right.
yeah, it's open to me, but
I'd say that's going to have been one of my difficulties with this whole program, though, is that I'm kind of with what to Marty's point is I'd rather have almost a more all-inclusive list, because I don't know that the number 9 on the list isn't going to have some proposal that is actually going to be the most impactful thing that we've ever seen in rural healthcare. You know, if that's an EMS availability, transfer service. I mean, that's always my tough thing is just the unknown of what these applications are going to be and how it's going to impact, you know, one small group, or maybe it'll touch lots of corners of the state.
So just to be clear, Dr. Todd, and as we've talked about this, the application, I think, is more of almost a fill in the blank and checkbox. Because it's like you're going to get X product, right? You're going to get an RCM solution, and we're going to evaluate where you are on the list in terms of the dollars available based on this criteria we've established. If it's open-ended, I absolutely agree with you. You never know where the creativity is going to come from. And I think we saw that in the other funding pools. But here it's like saying, okay, we could do it that way, but I think we can be more impactful for transformation doing it this way.
I gotcha. And that makes your good point. Good point.
Okay.
It's still a leap of faith, but
Is
we're all
there-
going over the cliff together, right? Please.
All right. I have to be the mean facilitator right now. So we do have a lot to get to, and I think some of this may, as we continue these conversations, it may become more clear. But for now, give me a thumbs up if we are leaning toward having eligibility more broad. Or we go with evidence-based practice grant eligibility with the addition of skilled care and potentially some ambulatory surgery centers.
I'm a little confused on what we're thumbs upping. Sorry, Sheena. But,
I know I
you
didn't answer
restate
that
it?
very eloquently. Okay, so thumbs up for keeping the eligibility similar or the same as evidence-based practice, or thumbs down. We want to make it more broad.
You want your answers in chat?
Chat, or you can give a thumbs up by a reaction just to see consensus. Yeah. All right, eligibility. So mirroring evidence-based practice grant eligibility. Okay. All right.
With the addition of ASCs and SNFs.
Mm.
You know, the other one I forgot was home health agencies.
Oh, yeah. Right, and local health departments.
Oh, yeah. There's so many provider types. Yeah.
Okay. why don't we, in the meet, how would we do this? Sorry, I'm thinking about this in real time. Here. Um,
Was there a reason that we didn't want to do clinics that were like mid-level clinics, like independent mid-level clinics?
Oh, Doug, that is such a good point, because for EBP, we did that, and that, I think you're absolutely right, we should have the MPPs in here. I always forget we made that distinction for EBP.
okay. Okay, I've updated the list that would be eligible based on this discussion. So
Mid-level providers? Okay,
yeah.
thank you.
So it would be so eligibility through EBP plus skilled care nursing facilities, ambulatory surgery centers, local health departments, and mid-level providers. Do we like?
Thoughts on LHTs?
Yeah, thoughts on LHDs.
Any limited to their actual delivery of healthcare services, right?
Okay. All right. All right. For location, this may be a little easier, and I think we'll get to more detailed discussion on the prioritization, but for the EBP grant eligibility, it would be only locations located in rural areas are eligible, and there it's using the FORP definition, the Federal Office of Rural Health Policy definition. And so not eligible, or at least locations that are not located in those rural areas. Are we good with that? And then we can prioritize rurality from there. Okay. Lots of thumbs up. I love it. Okay. So implementation status. Funding is limited to acquiring and implementing one of the selected technology solutions. It would not be available to reimburse providers for amounts already spent on acquiring a different technology solution. So you can't, if you've implemented something and you've paid for it, you can't get reimbursed for that, for instance. How do we feel about that? Okay. Thumbs up.
I think, Sheena, related to that is, and you don't get to go pick your own product either.
Oh,
right? Yeah.
It will be clear that this will be done through RFP, and you'll have a solution that's been identified and vetted. Okay. All right. I think we can move on to prioritization.
Kristen, did you want to jump in
I was just
before
going to
I
say
move
really
this
quickly,
along?
Sheena, do we want to, on the additional considerations that ETC has discussed previously, is everyone still good with these?
Oh,
And
right.
with that, we'll want to craft then the wording for that interoperability and evaluation commitment that will go into the RFA as well.
Yes, apologies, I missed that piece for sure. So as a condition of receiving funding, they'll have to complete the needs assessment. They will have to pledge or make a commitment to data sharing and participation in evaluation processes. And if they are multi-site, they will have to document how they're working with the rural sites, or how the rural sites are receiving the funding.
Is everyone still good with that? Keep that all inclusion?
Good. Okay. And this is pulling in from our previous discussions and consensus from the group. So just wanted to do that double check. Leland Liz and Leland, are their urban sites receiving the same solution? This is something we'll have to discuss here in a minute. As we think about technology readiness, do we include some consideration of the applicant's existing EHR and the ability to integrate with existing systems? Kristen, do you want to address that?
Sure, I was actually just typing a response, but
Okay, good.
Leland, 100%, which is with this incredibly expedited timeline, the assessment becomes even more critical. So for ambient, it's going to be likely less complicated as we start to think about the integration with the EMR than what revenue cycle is going to be. And so that's the reason that we determined that the assessment needs to be required part of the application so that we can understand where they are starting from and what those needs are. That may come in, well, one, help us really refine and get tight on what those technical requirements are. But as we work through that, this group can use that information also to start to prioritize in the prioritization for potential sites that need help on getting their EMR up to even be able to handle that integration. So they may not be someone that we select for year one, but we understand that there needs to be support to be able in year two to get them up to that spot. So that was, as we talked about trying to meet this timing, there were pieces that we said had to get done first. We had to have that knowledge so that we can make sure we're getting solutions that can meet those needs. Did that answer your question?
Yes.
Okay.
Perfect. Thank you.
Okay, we're going to move along and talk about rurality because that's what we're all here to discuss to make sure these rural providers are getting, the funding is getting to rural providers. So I'm going to turn it over to our resident expert on all things rural, Wyatt. He's going to walk us through this piece.
I'm at least the one that finds rural definitions very fun and interesting. So, so this is part of, we're getting into prioritization. So thinking about, we talked about eligibility, who can even apply. Now we're saying you've applied, and where this is going is we want you to tell us which of these is most important to you. And so eventually, before the end of this call, we're going to have you tell us, I think I want to weight this higher than this, or I want more preference given here than here. But to get there, we want to give you a sense of the things that we've pre-identified based on your feedback thus far as areas that could be used to prioritize among all those applications that come in. So when you all get to the stage of saying, how do we put them in order and give preference, these are some things that can be used to do that. And the first one is level of rurality. So we talked about eligibility side using FORP definition. FORP definition works really well as eligibility criteria. It gives you a simple yes, no. You either are or you aren't. It does not work well if you want to have any weighting. If you want, it does not have a range. There's not more or less. So if you all thought level of rurality made sense to include as a potential prioritization mechanism. So you want to, for example, give more points to more rural places and less points to less rural places. One of the ways that could be done that would be fairly easy to implement and understand is through the KDHE peer county groups. So this is used by the state health department. It's simply population density, and there are 5 groups. Frontier in white is less than 6 people per square mile. Rural is in blue, and that's 6 to 20. And then we go up from there: green, densely settled rural, semi-urban, and urban. This could be used as a way to give more points to places, to applicants that are more rural. There are many definitions of rural. This is one as an example to consider that would be fairly easy to implement. So I'll pause there about sort of thinking, if we go back to our overall potential areas of prioritization. do you all want to have a way to prioritize based on the level of rurality?
I mean, sorry, Liz and I are in the same office here, but do you have a way to match up rurality with need? So is there a way that you can balance? There might be a rural provider in a very low density that's actually, because of taxing structure, somebody's doing quite well. Is there a way, do you all have within KHA or KHI or others to know that, hey, these 60 facilities, because of their rurality and other economic indicators, is there anything like that? I'm not saying that's the approach we should take. I just wondered if you already rank need within these communities.
Can definitely look at operating margin for hospitals, but beyond hospitals, that's really difficult to quantify outside of getting direct data from the applicant.
So Dick, and when we talk about ambient AI again and I don't want to get us off, I know we have timing here, but for ambient AI, we likely will be able to meet the need with the funding. The questions you're asking, I think, really come into play as we start to look at the RCM tools and being able to prioritize need with the selection. One, because the solutions will likely be more expensive, but also if someone is already performing really well and is not having the denials or has a really low claims rate on a monthly basis, we'll want to figure out how to prioritize them differently. So, for ambient specifically, do you feel that having that need-based on top of the rurality is as important as it would be for potentially other use cases?
No, I think you're right that I think with ambient, that's a little bit simpler. I think when you're looking at the entire revenue cycle, which, can dramatically, all these things impact, operating performance. So, that's why we're trying to address them. I just wondered if you all already had an attitude around these guys really need help. Okay.
I think when we talk about the access hardship, that might get into it a little bit more, or it may be a different way of thinking about it. But maybe if not, after that we can still. That's something we could add.
So
Definitely.
maybe now, and we jumped into, and Chris, I'll come to you in a second. We jumped into this first one and gave you an example of some of the nuance that will happen in each of these. So if you all say this is something we want to consider, then we have to think about a way to put that into practice. So if we want to consider a level of rurality, we need something to base it on. If we want to consider facility type, we need to identify those facilities, et cetera. But before we maybe zero in, back up and talk about these general areas and what is pre-identified, what's missing, and then we can dive into any specific one. So when we think about access hardship, one way that we've thought that could be put into practice is thinking about access to providers or access to care. So we could look at, though it's imperfect, health provider shortage areas as a way to think about that at a geographic level. The data is readily available, and that could be used. Facility type, we've discussed the different types of facilities, but there could be prioritization for certain facilities over other facilities. In addition to eligibility, you could then go a step further and say certain facilities will get more points or less points. Documentation let me go to in order readiness evidence. We think about trying to find ways to verify that they are ready to implement this. Do they have an existing policy? Do they have a clinical champion? Do they have a platform? Do they have staffing? That there's a lot of questions there about how that could be measured. Documentation burden. We think about how do you measure the amount of documentation burden that this tool would be used for, think about the provider count or encounter volume. And so there's a lot of potential ways to think about that as well. And the last one, geographic distribution, is more at a global level that we've heard. And again, we've tried to pull together all the different feedback we've gotten to this point and propose you something to respond to. Geographic distribution. Do we want to intentionally not let all the grants go to one corner of the state or one region of the state? Is there at the global level some preference that these dollars go all corners of the state? So that's the overview. And now I'll back up. I know, Chris, you were in before Derek. So if you still want to jump in, I'll come back to Chris and then
I lowered my hand because you answered my question. It's hard to think rule alone without kind of thinking through the other boxes. So appreciate you walking through that.
Thanks.
Yeah, and I was just going to ask to Marty if there were with any of the other projects up to this point, has this question been posed on rurality and ranking thereof? Is that something you've tackled on any of their projects, and would it apply here?
I think we're plowing new ground, Dr. Totten.
Kind of the nuances, and I was thinking of with the level of rurality. Yeah, exactly. Was the healthcare isolation or distance from another acute care facility, anything like that? Talk about geographic distribution in another way, I guess, of patients being served. Obviously somebody that's located 20 miles away from a Hayes Med is going to have a lot different needs than somebody who's located out on the far fringes of Western Kansas. So they get a greater priority than just frontier designation.
And we have that data because of the AHAP analysis.
Yeah, Scott, you said exactly what I was thinking as well. I think that it matters from an ambient perspective of making sure that
recruitment.
Just because it's just exactly.
Other feedback and discussion across these areas, or if something's glaringly missing, or you all say, I don't want there to be a prioritization of that, you can remove things as well.
So an additional question would be, as we look at readiness, evidence, and documentation burden, and I know in some of the previous calls, Scott and Chris, you both had some thoughts on how you were measuring those within your own facilities. So what would we want some of those measurements to be that we would want to prioritize on from a readiness or a documentation burden?
Kristen, were you asking, were you asking how would we assess readiness?
Yes. So what would we want to use as the criteria? So if we're going to use it to prioritize, should it be EMR readiness? Is it on-site support? Knowing we'll need to be able, both the vendor partners as well as potential implementation, but what is some of that criteria you all would want to say this is going to be important for us to prioritize?
Well, I mean, number one is, that, a contemporary EHR infrastructure so there's actually interface to it. Now, you may have a separate program if you've got some laggards out there that aren't even on a contemporary system. But I think for this round, go fast, make an impact. I think you're going to say it's uninterfaceable, and we can come up with some language there. I think that's really important. I think some ability to dedicate, 0.3 FTE for the project or something, that there's someone that has some of that skill It could be, you know, I understand that roles are completely shared in those things, but because the vendor's going to bring some talent, and we hope, you know, if it's contemporary interop, and you know they've got the implementation is going to have to be simple. That's one of the things we're going to look for, and they'll bring some project management help, but there needs to be a coordinator of some type. It could be, you know, a small percentage, but a willingness to commit some small percentage of a person to do the project.
Yeah, and I would add, clinical engagement and champions kind of a big one because, and it's not just one time upfront or during implementation, but there's going to be an ongoing making sure that there's a dedicated clinicians that are providing feedback near real time and making sure that the product is functioning ongoing. And so those are, I think, the other important factors.
Thank you. Okay, with our 9 minutes that we have left, this meeting had been planned and we kept it at an hour and a half. For the last 2 meetings, I did want to make sure that we could talk about that other prioritization criteria under revenue cycle management. So we can talk through that. So the only thing that was identified for your that the team had identified that might be different, or we wanted to make sure to talk about for RCM prioritization would be financial stability. So thinking about financial stability, are there considerations around that in order to be able to implement and receive funding for an RCM related solution? What considerations should be taken into account?
I have a question for, do we have measures for FQHCs and CCBHCs that are there objective financial stability standards? I mean, for hospitals, again, we can look at operating margin, that's in a cost report. But is there some sort of source of truth for those other types of providers? Terry, if you know over the FQs.
Yeah, they've got to do Medicaid and Medicare, well, Medicare cost reports, but then they have all the reporting to HRSA too.
Got it. And I'm not sure, is it Michelle who's on today from the association?
Kyle.
Oh, it's Kyle. I'm sorry. Kyle, is there something similar for CCBHCs?
In terms of I'm sorry, repeat that again.
Sorry, for a measure of financial stability that we, some objective outside criteria that one could look at.
Well, I thought that's what you were asking, and I didn't totally understand it because I don't know if I would characterize it that way.
Okay.
I think that in terms of licensing requirements and even the certification requirements, people will regularly, and they're all their boards of directors, right? They have private boards of directors that look at their annual audits and things like that. But in terms of a key performance or a key indicator, it's hard for me to really identify that.
Yeah.
And so for a slight clarification, this would allow us to, coming back to what Dick mentioned on the last prioritization criteria, is really identify those facilities providers that need the most help financially. So being able to, does that become a prioritization criteria to say we want to make sure that we get them in those first rounds if they meet all the other criteria versus someone that has a very healthy financial situation?
And Kristen, I appreciate that clarification. Just because some of what we sometimes see when we're looking at this is, are there other places to pay for this already? And you don't need to go through RHTP funds, which could go to an FQHC or a rural hospital or something like that. But the technology piece is someplace we're interested in because there is less and less available resources. And traditionally, there were very few resources available for funding this area. So things like ambient AI and some of the things that are really taking root out there are significant. And so really looking at reserves and things like that, unless they're paying out of that, there's not a natural not a natural funding mechanism, if that makes sense.
It does. And maybe Kyle, we can continue to talk around what would be that measure that would help us get to that information.
Okay, happy to.
Thank you.
Okay. In the interest of time, I know we're having some comments in the chat. Thank you so much for commenting on readiness. So we'll make sure to include all of that, and we'll summarize all of this feedback and send it back out to you after today's call. It may look at an offline way of gathering additional feedback or getting answers to key questions before it's finalized. We'll go ahead and move us along. And so thinking about moving from this more detailed discussion to weighting. So we have our categories for both ambient AI and RCM RFAs. Thinking about when they're filling out the application and how they're going to be scored. We're going to do the same process as we did at our previous meeting, where you'll have 100 points to allocate between each of these areas. So the first one will be for the ambient AI, and this will help us, help the team who's developing the RFA to determine the weighting. So how important do you think the level of virality is versus access hardship or facility type? It will determine how they were scored, and we just want to get a general sense from the committee. Should it be everything be weighted the same, or are there certain, do you just want to make sure really rural places get it, or do you want to make sure that certain facilities definitely get this funding? Kind of is how we're thinking about it. So going to go ahead and ask you to complete using your phone or device, or go to menti.com and enter in the code.
And Shelby just dropped a link in chat for you. So I know we're running up on a time boundary, but this is really important. And we want to give you all a chance to say, this is really important to prioritize. This is less important. So please provide that. And then I'll advance the slide, and you should be able to then do the same thing for revenue cycle. But I will give folks a minute. And is it working for folks? Are you able to, can I get a thumbs up? Cool. Head nods. Okay, great.
Yep, I'm seeing the results come up. So
I've got the results hidden because I don't want you all to be swayed by your peers. Want your individual honest feedback.
And it's important that we hear from each of you. This is the most time critical information we need to get in front of KDHE to be able to bless this criteria. It will then go into the development of the RFA and the assessment, which we want to be fielding here within the next 2 weeks as well.
I'm going to advance to the next slide. You should be able to continue with ambient AI if you're not able, or if you're still working on it. But it's the same process, so you should be able to advance to the next one in the same link.
Yep. So we have a couple minutes left. So yeah, really spend some time thinking about this. And if you have really strong feelings, you can always reach out via email or thoughts about any other items that we've discussed today, any suggestions. I will place my email in the chat for you.
I'm clicking us along, so we want to get folks out on time, and we gave a preview that we may invite volunteers because this is happening really quickly. So I'll pause here to invite Kristen and Shelby and Sheena, maybe mention that.
Sure. So as we look at the RFPs on the ambient, we have collected a lot of information from all of you on the operational and some of the cultural pieces that we want to make sure that we're including in the ambient RFP. In addition, Scott has been a fantastic partner in sharing what the Oracle product is going to be, so we can make sure that we are able to match that for all of our non-Oracle providers. As we get into the revenue cycle management, as Marty mentioned, we already are moving forward with a similar RFP and with AHAP that has already been fielded, and we'll actually be getting the responses back in this next week. But what we'd like to do is, knowing that not everyone that sits on the committee has that technical expertise, we would like to get some volunteers to create a smaller group of advisors who will really help review those technical requirements as they are built in, and make sure that we're really representing the voices of those smaller FQHCs, independent providers that don't have a voice here, but making sure that we appropriately translate what those assessments come back to be into technical needs. So I know it's an ask for some additional thought leadership, but if we have some of you that are willing to serve in that capacity, it'd be greatly welcome.
And please email Shelby, and she'll help coordinate some of that logistics so you can provide that feedback. It's 2:31. I want to just before you hop off, if you're still on, thank you for the extra minute or two. I want to let you know about a couple upcoming events and some timing for that. And the webinar was mentioned previously today, but that middle one, Kristen, very brief in 20 seconds.
Sure, great. This is several meetings ago, you all voted on what would be the topics that would be most compelling. The group voted on the harnessing data to deliver real-time decision-making and what is possible. Again, I think some of you that helped inform us with some additional detailed questions that have gone into an outline. And we will be we have the Chief Innovation Officer from Houston Methodist that will be leading that webinar on September 29th. So stay tuned. We will have some press pieces that are coming out with links to be able to register. And then one last update for all of you. We covered this in a previous meeting as well. The Global Health Innovation Summit for BioSTL is in October. With the state of Kansas, we have 75 open seats for any of you or any of those facilities and providers that you support to be able to attend. We do have additional states that are participating. It is not going to be just St. Louis and Missouri, and Kansas. We also have Massachusetts, Kentucky, Nebraska, Arkansas, Iowa, and Tennessee that will have some presence from their rural health programs as well. So if any of you wants more information on this, feel free to reach out to me. We have a link that will be going out to everyone as well. And the focus will be on bringing in innovators that match the prioritized areas that you all have identified, and some of the other providers across the state of Kansas have identified as rural needs in RHTP. Sorry, that took 2 minutes, Wyatt.
That's okay. Thank you all for the time. Flag. We'll see you again soon. September 24th, we'll have our next meeting. It'll be virtual again. Thanks for the extra time. Thanks for the great discussion. Please watch your inbox. We'll be following up soon with more information. And if you have interest in volunteering to be an additional, to give some additional time and be a technical reviewer, please reach out to us. But thank you all for all the time and discussion today. I know it was a lot and nuanced and it's complicated, but we really appreciate everyone being